be determined to support a lasting recovery while promoting equitable, sustainable and inclusive efforts that leave no one behind. And therefore, I'm extremely grateful really for organizing this webinar and also for the excellent speakers that are today with us. So thank you very much once again, and back to you, Ingrid, or Caroline directly maybe.
Thanks a lot, Iveta, for your nice introduction. And I'm also very happy to welcome you all here to this webinar. It's great to see so many of you joining us. As it is an important day today, not only for this webinar, but also today the Global Health Summit is taking place in Italy, which is linked to the G20 conference. And EuroHealthNet has contributed and provided input to the consultation process linked to this Global Health Summit. So we hope that health equity is featuring on their agendas, because we know for a long time that inequalities are the root causes to many of the problems that we are seeing in our societies. And with COVID, now we have seen that many more people are aware of the existence of health inequalities more than ever before. I mean, health inequalities are on the news, in TV talk shows, it's high on political agendas. So we now have, as public health professionals, we have the responsibility to live up to these expectations and demonstrate what solutions are out there and what strategies works. Because in addition to health inequalities be on the political agenda, also huge funds have been made available for generally the recovery process. You may know that the Commission has now freed up 600 billion euros for the resilience and recovery funds, and countries are currently developing their plans on what to do. And of course, we need to be there with our suggestions on how these recovery plans can contribute to health equity. The EUPHA Health program of the Commission is 10 times bigger than it was before. So again, we need to be there and demonstrate, okay, this is what works. So I find this webinar also very timely, and I'm very happy with the excellent set of speakers that we have invited, because they will be able to share with us their lessons and their knowledge on what works and what can be done. But before I introduce you to the first speaker, I would like to highlight 2 points. The first point is that EuroHealthNet has just launched a new tool. It's our Health Inequalities portal. And this tool holds a database with many resources, literature, but also good practices and policies. More than 600 resources are included. But we also explain how the funding programs, how they work, and we describe the funds available for possibly addressing health equity. So I hope this tool is really useful for you, and I would like to encourage you all to submit your ideas and good practices to our database. And secondly, EuroHealthNet is supporting Jahi, which is the joint action on health equity. This is a DG Santé funded action where 24 member states are working on addressing health equity, and they have a big focus on implementing actions in their countries. It's led by ISS, the Italian National Public Health Institute, and I know that Bernadette Kumar is speaking later today, and she is the work package leader of Jahi, so she may be able to tell you a little bit more. I will stop here. I would just like to indicate that please use the chat function if you have any questions or comments, and we really would like to hear from you. And I will now introduce to you our first speaker, and I'm delighted to introduce to you Clare Bambra. Professor Clare Bambra is working for the Population Health Sciences Institute in the Newcastle University in the UK, and we work with Clare in the context of CHAIN, which is a global health inequalities center based in Norway and NTNU. And Clare has just written a new book, and she will now tell us all about it. So Clare, the floor is yours.
Thank you very much. I will just share my screen. Good morning, everyone. Thank you, Caroline, for that kind introduction, and thank you for the opportunity to talk to everyone this morning about COVID-19 and health inequalities. And as Caroline kindly said, we have a book coming out next month, which is discussing various aspects of how the pandemic has exacerbated, exposed, and increased health inequalities. But today I just want to talk through some of the key issues in the COVID-19 pandemic from a health inequalities point of view, to set the scene for the speakers that come, who are going to talk about what we do about some of these inequalities. How can we improve things in the future? So I'm going to talk about some of the epidemiology around inequalities in COVID-19, just setting out some indicative data about the extent and the different types of inequalities we're experiencing. And then I'm going to present the concept of a syndemic pandemic, thinking about how we can understand why COVID-19 has had such inequalities and some of the pathways through which these inequalities are occurring, and therefore the ways in which we can try to address and reduce health inequalities, not just in COVID-19, but in the underpinning clinical risk factors in the future. So, as Ingrid said very helpfully in her introductory comments, initially in the pandemic, it was very much presented that COVID was something that was affecting everyone and affecting everyone equally. And these are comments that have been made in the past as well. 100 years ago with the 1918 Spanish flu pandemic, similar comments were made that it hit rich and poor alike. But of course, it became quite apparent quite soon that that wasn't the case. And this is just some data from early in the first wave, which shows the extent of the issues. So this is data from England, and you can see here, this is neighbourhood inequalities in COVID-19 mortality. So the least deprived areas compared to the most deprived areas. And we can see that the bottom 30%, so the most deprived 30% of neighbourhoods in England had a mortality rate from COVID-19 more than twice as high as the least deprived. And to put that into context, then we can see in terms of figures, I know we have a colleague from Public Health Wales speaking after me, so we can have a look at what's been happening, for example, in Wales. And we can see that during the first wave last spring and summer, then the COVID-19 mortality rate was over 100 deaths per 100,000 in the poorest areas, more than twice the kind of 50 to 60 deaths per 100,000 in the least deprived. And these are patterns that have been detailed not just in the UK context, but in America, in Germany, for example, where there's big differences between employed and unemployed, in Sweden, where there's big inequalities, for example, by migration status. Here again, some more data showing, so we've seen that there's neighbourhood inequalities, and we can also see data here from the UK government about occupational inequalities. And we can see that people in less skilled, more manual work have a mortality rate more than twice that of people, in this case for men, in professional or managerial jobs. The gradient is not quite so steep for women, but nonetheless there's still differences by people's occupation in terms of mortality rates, potentially related, of course, to exposure. And from a UK context, perhaps the most important kind of inequalities revelation for us has been around ethnic minorities and the very high rates of COVID-19 that these groups have experienced. Health inequalities kind of policy, narrative and research in the UK has always very much been focused on deprivation and occupational class. But the pandemic has really shown to us that as researchers in a public health community, we also need to take a more intersectional approach to health inequalities and to think about ethnicity as a really important factor as well. And this data is quite stark and I think has really opened up the eyes of the public health community in the UK, as we can see, for example, here in case rates and also horrifically in mortality rates, a massive impact of COVID-19, massive inequalities, particularly between Black British men and white British men. So COVID-19 is not just about rich or poor, it's also about other aspects of inequality, particularly here around being a member of an ethnic minority. Together with colleagues, we've written an article and subsequently followed up with a book trying to explain this in terms of what we're calling a syndemic pandemic. That's not to say people have been sinful, far from it. It's about thinking about how the idea of a syndemic comes from the anthropologist and clinician Meryl Singer, who in the 1990s looked at impacts of HIV, drug use and violence in the American inner cities. And he wanted people to think of them not as single risk factors that needed to be dealt with individually, but as a mixture, as a syndemic, as a combination of influences. And we wanted to apply this across to how COVID-19 is leading to health inequalities, and to think of it using this diagram as an interaction of the existing inequalities in the social determinants of health, leading to inequalities in non-communicable diseases, which in turn then lead to these inequalities that we see in COVID-19. And just to unpack the diagram and the idea a little bit more, we think about this in terms of 4 pathways whereby we're having these inequalities in COVID-19, whether it's by deprivation, occupational class, or other axes of inequality. So firstly, we can think about the increased vulnerability that certain social groups have to adverse COVID-19 outcomes. And this comes in terms of their experience of the social determinants of health, which over their life course has led them to be more likely to have underpinning clinical risk factors such as diabetes or respiratory disease. The second one is increased susceptibility. And this draws on the psychosocial idea of health, whereby people's immune systems can be weakened over time by chronic exposure to adverse living and environmental conditions. So, for example, we know from studies into the seasonal flu virus that people from more deprived backgrounds have a worse response to flu because their immune systems are not as strong as people from more affluent neighbourhoods. Thirdly, COVID-19 inequalities are very clearly coming through increased exposure in some groups versus others. And a clear one is around working conditions. So when we look at that occupational gap between managerial and professional groups and more manual and retail groups, then clearly the lockdown and the impact of working from home for people like us has protected us from exposure. In the meantime, people who still need to go into the office, into their workplace, who tend to be on lower income jobs, are still having a much higher level of exposure than professional groups. And fourthly, we need to think about how the virus is transmitted. So look at differences in transmission. And this, it can be done, for example, through inequalities in housing conditions. It's easier to self-isolate if you have space to do so. And it's much harder if you live in an intergenerational household. And it's also the case that it's much easier to self-isolate if you're infectious, if you have sick pay from your employer, which pays for you not to have to go into work. And that's not something that is accessible to everyone. A fifth pathway that we now need to think about as the vaccines are rolled out across Europe is around how this could end up being an additional pathway of inequality. It's brilliant, the progress that's been made on the vaccine. And as you know, the UK has a very high vaccination rate at the moment. But there is also inequalities in uptake and distribution of the vaccine. So as we can see, this is data from March in the UK showing that there's a gap in terms of the uptake of the vaccine between the more deprived and the least deprived neighbourhoods. It's smaller at the higher age groups, but it's slightly larger in the lower age groups. And this is part of what might be driving some of our difficulties with the Indian variant at the moment. So I will conclude now just by talking about and hopefully introducing the topics of the next talks and speakers, which is about how can we avoid this in the future? What can we do about these inequalities in COVID now? And how do we prevent them in the future? So we can see that the inequalities in COVID are not a surprise to us as a public health community. They relate to underpinning inequalities in the social determinants of health, which we've known about for a long time. One of the immediate things we need to do is obviously ensure that the vaccine rollout is accessible to everyone. But in the longer term, we need to reduce the existing health inequalities in NCDs, and this requires action on the social determinants of health. I will conclude there and open the floor, return back to Ingrid. Thank you, everyone.
Thanks a lot, Claire. This is for me for now, and then we move to Ingrid for further questions. So thanks a lot, Claire, for your excellent presentation as ever, and indeed astonishing the figures that you were showing us, that the COVID-19 death rate is more than twice as high for most deprived groups, and how indeed ethnic inequalities are huge, and that we need to address it. And I find the syndemic of COVID-19 and also the image that you've produced really helpful, and has helped us a lot over the past year to make the case for health inequalities and how important it is to address them. So thanks a lot for your work, and I can recommend everyone to read your book. I had a privilege to have a look at the preview, and I can really recommend people to read it. So we will do questions afterwards, but first I would like to move now to Wales, to Dr. Mariana Dyakova, also an executive board member for EuroHealthNet, and she is the International Health Lead at Public Health Wales and Deputy Director of the WHO Collaborating Centre on Investment in Health and Wellbeing. And Mariana, you're doing a great work in Wales, and I look forward to your talk. The floor is yours.
Thanks a lot, Caroline, and thank you for this invitation. And it is brilliant that the presentation follows from Claire's. It sort of builds nicely and sort of follows up nicely from that. So I'll share my screen now, and hopefully it will all work out. Do you see my presentation now?
Yes, maybe you can put it on the slide show mode.
Is this all right?
Yes, perfect. Thank you.
Okay, I'll just minimize this so you don't. Okay, brilliant. Okay, I'll be very quick because we actually have an hour on presenting our work on inequalities and the impact of COVID between 1 and 2 Central European time. So there is a specific workshop webinar we have organized presenting the findings of a report we did. So I'll just highlight a few key things, and then you're welcome, whoever is available, of course, to join us at 12 o'clock UK time or 1 o'clock European time. As a start, I would like just to highlight that Wales hasn't been obviously as part of the UK, it hasn't been alone into the impacts, feeling the impacts of the pandemic, but also responding to these. So we've been working in close collaboration, of course, with our colleagues across the UK, as well as in Europe and internationally, closely with EuroHealthNet, with the EUPHA, and of course with the World Health Organization as a WHO collaborating centre. So we've had a number of activities as a Public Health Institute for Wales, which have been trying, of course, to address directly the pandemic, but also to look into the more indirect impacts on the population, and also from the measures which have been taken to contain the virus. So we've been very much working to inform the day-to-day response, but as well as to try and be more proactive and see how we can mitigate potential harms from COVID. And there are also identification potentially of some opportunities for building back better as we started this webinar. A key element we've been working around is an agreement between WHO and Welsh Government, a memorandum of understanding which was signed last year in the area of health equity and sustainable investment, and also creating an economy of well-being, leaving no one behind. So this is based, of course, and linking with the 2030 Agenda for Sustainable Development and the European Programme of Work. And Wales has been the first country, one of the 3 countries currently, to implement the WHO Health Equity Status Report Initiative and develop our own Welsh Health Equity Status Report Initiative, and currently developing a Health Equity Solutions Platform for Wales. This is around 5 essential conditions. So we are using, and if you're familiar with Health Equity Status Report Initiative, which was launched in 2019, it uses a slightly different way of packaging or classifying the wider and the social determinants of health into 5 areas: health and health systems, income security and social protection, health and living conditions, social and human capital, and then employment and working conditions. So we've been using this new WHO framework to frame our work around inequalities, and particularly around translating research and evidence into policy and practice interventions and solutions, so to say, to accelerate action towards healthy, prosperous lives for all. So our work and the report we published at the end of March is focusing in Wales, but it is using this WHO framework. But the unique perspective for of this report is not that much, and Clare has already shown quite a lot of the or some examples of the evidence of the inequalities which have been highlighted in the UK and also in Wales. But the unique element, the unique sort of perspective of the report is combining different types of data and also the policy responses. So we have on one side the evidence, but we also have a public engagement survey where we have looked into the public and people's perceptions, both in terms of the pandemic, the virus, but also in terms of the responses. We've taken also data from statistical data and administrative resources. We've done some economic modeling, and we've also looked into the policy responses across the UK and Wales. So very briefly, again, I'm not going to go into any data because we have an extensive 1-hour session where you're welcome to join us for the data. You're welcome, of course, to look at the report. There is a live link here where you can download both the report and our technical supplement. So as Clare already highlighted, and it's not a novelty across Europe, unfortunately, COVID has exacerbated and highlighted existing inequalities, but it has also, not only highlighted, but exacerbated existing inequalities. It has shown the fragility of health systems. There was a very interesting webinar I attended yesterday, which was linking health systems with health security. So obviously, the strength of each country's health system had a major impact on the response and mitigating COVID harms. We have seen that the impact of impact on livelihoods have been unequal in particular groups. Like, for example, minority, Clare underlined, but also children and young people deprived of education for long periods of time. Women, particularly, again, employed and also people in unsecure, low income or informal employment. people living in risk of or at risk of deprivation and poverty, and particularly socially excluded groups such as homeless persons and asylum seekers and refugees. There are key messages in each of these 5 essential conditions, which I've highlighted at the beginning, which I'm not going to go into detail. But again, as each crisis, COVID has highlighted some opportunities, and we do have now an opportunity to rebuild our healthcare systems and economies, if you want, and wider sectors are better. So it is an opportunity not to return to the status quo and have a synergetic and transformative recovery. And it is an opportunity if we strengthen again and invest in public health and prevention and early intervention and strengthening our health systems, and particularly public health, to prevent actually future such pandemics and crises rather than be more prepared for them. There's a few more insights from the report around the opportunities going forward. So we have identified more than 70 policies. So there has been a major governmental support during the pandemic. However, of course, these are a lot of these policies, most of these policies are actually have been created or renewed, particularly for the pandemic. So so they are temporary and not always specifically targeted. So there is definitely a need for continuity and consistency and a review of these and which ones need to be continued maybe in the longer term. There's some positive impacts around active travel, strengthening community assets in terms of volunteering, and creating opportunities to supporting the local economy. Some potential enablers and equalizers identified, like education and digital technology, using an intergenerational lens in the response and recovery, looking, of course, into the impact of older people who have particularly impacted in a direct way. We have a lot more cases and deaths in the older age group, but at the same time, we had younger people and children and young people severely impacted by the indirect consequences and the measures. And of course, working in a sustainable way and adopting a circular economy. The case for investing in public health and reducing inequities is stronger than ever. So this is a real opportunity, and I've been hearing it across a number of networks, the Healthy Cities, the Regions for Health, EuroHealthNet, our, of course, board sessions. It's unfortunate, but every crisis, again, provides an opportunity, and this is particularly highlighted inequities, and now it's really the time to be able to make the case for investing into addressing this. And of course, we've been particularly lucky in Wales having an enabling legislation, and we just implemented, came into force a socio-economic duty in March this year, which makes it's an obligation now for public bodies to consider the social impact of any policies and practice they're committing to. And of course, we are developing this health equity solutions platform for Wales. So these are all of the resources. So yeah, please do come along at our session, and you can register the link, and then we have a more sort of detailed look into the different types of data, public perceptions, the international evidence, and health impact assessment, and so on behind these conclusions and the policy response. Thank you very much.
Thanks a lot, Mariana, for setting out all of the good work that you are doing in Wales, and I can indeed recommend your seminar for further details. I think the WHO Health Equity of the Venice office is doing great work, and there are other countries also applying the health equity tool as you did in Wales. It's in Italy and in Slovenia also. They are trying it out. So if you're interested in how this tool is being applied, I can recommend you to indeed go to Mariana's session or to get in contact with the WHO Venice office. So there are some questions in the chat, and I would like to ask Ingrid to see which questions are there which you would want to highlight.
There's more a comment about highlighting from Florence, highlighting the irregular migrants and the health situation there, that they've been greatly hit. Actually, the next session will look into healthcare systems and migrants. So maybe it's more of a comment that they're looking into that. There are, and then someone who's registering to your to the next seminar, so that's great, Mariana. And indeed, not everyone can go, so I think it's important to get that information up front, because it's great to hear really about specific policies. I have a specific question, since there are none there, just in terms of, I think, Mariana, you mentioned 70 policies that are being developed, so that's really great in terms of, this really leading to action. Claire, at the end of your book that I also had a chance to scan, thanks, you also mentioned some lessons learned and policy solutions, and they're quite broad brush, but I'm very curious if you could just, of course, we can't change the world immediately, but if there is one initiative, one policy solution that you think, can we just get behind that and push forward, it will at least make a difference? What's something that really comes to mind in terms of, if we're kind of solution oriented, what would you really want to see happening, and a change in which area to that can really catalyze something that can catalyze change in the area of health? So maybe an interest, because again, it's vast.
Yeah, I mean, if we're talking long term, then I think the focus for me at the moment is on child poverty, which was already very high in the United Kingdom. So just for European colleagues, it averages around 30% of children are growing up with less than 60% of the median wage in their household. In some areas, like where I live in the north of England, then that rate can be 40%, and it has increased over the last year. So I think there's a very strong association between child poverty and obviously immediate outcomes like infant mortality rates, but of course we know from life course epidemiology that has massive impacts on children's cognitive development and how they go on into adulthood, their employment opportunities, and obviously their health and well-being across their life course. So if there was one thing that I would do if I were, the Prime Minister of the United Kingdom, then targeting that would be what I would do. And it's achievable because it was reduced significantly in England between 2000 and 2010.
Okay. Well, thank you for that, because at the very end of the webinar, we have Professor Hugh Fraser, who will talk much more about specific actions in that area. So that is a nice response around. Mariana, maybe just one sentence of what area, or from those 70 policies, something that really stands out for you of, this can help to catalyze some real change that we need in the report.
Well, I would very much, of course, agree with Claire. I mean, children and young people have been particularly, we had already poverty beforehand, but we could see in the report has highlighted, for example, when children are not able to go to school, of course, there are issues around not getting free meals and of course, not being able to participate adequately in education because they don't have the facilities and the IT and also the support of their parents who are working, again, usually in key professions. So that's a key thing. We don't focus again into one specific. One thing which we've been discussing with the WHO and related to the history framework is usually it doesn't have to be everything, but it's a basket of interventions which would be effective into actually reducing inequalities. So you can never achieve a substantial, again, if we're looking in general into reducing inequalities, only through one policy, whether it's an employment policy or a housing policy or a social benefits policy, for example. The idea is looking into which areas has the most impact, and this is the next step we're working on. And the Venice office have done a decomposition analysis, which essentially tries to show the relative impact of each of these wider determinants or 5 essential conditions as they are, how much they form of the health gap. So if we have 10 years difference between 10 years difference in terms of life expectancy or healthy life expectancy, and we do have 10, 12 years difference between regions or socioeconomic groups, then how much of this is defined by the different elements, and then pick up.
Mariana, I'm just very conscious of time because we have quite a full schedule. So it's very nicely laid out, and in your presentation, I think please do look at all those links because it's very rich information.
It's a basket of interventions, picking up the ones which again, based on evidence, would make the most impact.
Okay, well, thank you so much to both of you. And I really, like Caroline, recommend looking at both Claire's new book coming out next month, as if I understood correctly, and the publications coming out of also that WHO and Public Health Wales looking at specific policies. So thanks so much to both of you for laying this out and introducing this theme and what can be done so well at the start. And I'd like to turn to Iveta now, who will introduce the speakers from the EUPHA network.
Yes, exactly. Well, thank you very much, Ingrid. Indeed, I'm truly delighted to introduce you the next speakers because these are my dear colleagues from the European Public Health Association. So the first speaker will be Dr. Ricardo Mexia, the president of the Portuguese Association of Public Health Doctors and also vice president of the EUPHA section on infectious disease control. And Ricardo will tell us about the different approaches in different settings towards building public capacity to face future public health threats. Ricardo, without further ado, the floor is yours.
Hello, good morning, everyone. I'm really glad to be here and to share the floor. So I'd like to greet Iveta and Caroline, as well as Ingrid for sharing, and of course, greet the rest of the panel, which I'm very honored to integrate as well. I'm going to share my screen to share a few concepts with you, but it's indeed very interesting what we've just heard. And in fact, health inequalities are being increased by what's been happening over the last year and a half, roughly. And therefore, I think that we should really be aware of what needs to be done in order to address these inequalities issues. On one hand, it's very important that we realize that we are in a context in Europe of very diverse health systems. We know that the approaches each country has, both on access, coverage, on the approach they have on disease prevention, on disease control, are quite diverse. And for a communicable disease such as COVID, there's also a very significant implication on cross-border care, because of course there's all the situations that may arise both from travel, both from the communities that are living and working in border areas. So I believe that we really need to address this diversity. And there's been some criticism on the lack of proactiveness of the European Union, of the Commission, on health. But we need to be aware as well that according to the principle of subsidiarity, health is not part of the mandate that the EU does have. It was the member states' decision not to allow health to be on that the responsibility of the EU. And I think that we've now realized that eventually we might need to rethink that approach and be able to, and there's several tools which I'll mention in the end that are quite directed at improving that situation, and of course collaboration and implementation of measures across the whole European Union and across all Europe. And of course, inequalities, as was mentioned by the two speakers before, are quite significant, both within countries and as well as between countries. We know that different countries face different challenges, and of course, that's also a matter of context. I'll try to address mainly those differences between countries over the next couple of minutes. One of the things that I think is very important is that, for instance, in vaccine hesitancy, we need to be aware that it's not something that we can overlook. And despite this being data from all of Europe shared, we realize that, for instance, being unemployed or being ill or having a disability is a significant factor for being more vaccine hesitant. And we need to be aware of this when we are designing vaccination policies. And of course, communication has played a key role in the whole vaccination process for COVID. And we had a lot of setbacks during this whole process. So I think we need to address the communication in a very significant way. And when I'm talking about communication, I'd also like to point towards this specific point, is where people who rely on social media as a news source are much more likely to be vaccine hesitant than those that follow traditional news sources. So this is something that we also need to take into account. And of course, social media is something that we need to address. Disinformation has reached a very significant level over the last year and a half. And that also is something that we know is more problematic among those that are facing inequalities. So I believe that probably something that needs to be considered as well. I would like to show you that it's also very different. Most countries have increased vaccine confidence between 2018 and between 2020. We need to understand that this was actually before vaccination was already in place. The COVID vaccination was already in place. But nevertheless, we need to realize that, for instance, in 2020, we had countries which had nearly half the vaccine confidence of the highest ones. So if you compare, and I need to be proud of this one here, so Portugal has indeed the highest vaccine confidence, and on the opposite end, we have Hungary, which is half the vaccine confidence of Portugal. And this, of course, poses significant troubles when trying to contain a situation such as COVID. But it's also a significant problem for other disease. We know that, for instance, measles has been an issue in Europe. While we should be facing elimination, we're actually struggling to contain significant outbreaks in many countries. So the whole vaccination problem is something that needs to be addressed, and probably the tools we have need to address that as well. I'll share some data on the impacts that the pandemic might have, and this data was recently updated with data from this spring already. And what we realized is that there's an increasing number of people that have lost their jobs, and that's mostly the same across Europe. If you look at the data for all of Europe, we're reaching a number of almost 10% of the people who lost their jobs. And this will have, of course, huge socioeconomic impacts, and that we'll be facing over the next months and even years eventually. And also, if you look at the asterisks, these mean that the difference is statistically significant from a comparable time before. So there's indeed a problem on unemployment that will be as well a significant impact in health. When we look at unmet needs for healthcare, that's also a big concern. We know that access to healthcare has been significantly hindered over the last year, as most health systems have focused on fighting COVID. And therefore, there's a number of people who could not have specialist consultation. Dental care is also a problem across Europe, but I'd like to focus on this third item. So there were unmet needs on nearly a quarter of the patients across Europe. So that's a very significant number of unmet needs that eventually will unfold over the next months or years as health problems that we might have managed beforehand if we were able to implement these measures. And of course, mental care is also always on the agenda, GP care, and of course, all the treatments that we're unable to deliver will also eventually have an impact on mortality. So this is something that we'll be facing across the next few years. Also, there's a significant difference between countries when we are discussing unmet needs. While we have countries as Denmark, which are slightly above 10%, but other countries are nearly reaching 40%. So there's also inequality across countries when we face access to care. There's also a negative outlook from the population, and we've seen that this is actually been aggravated between summer last year and this spring. So apparently people are having a bleaker outlook on the future over this last spring. So that's something that also can have a significant impact both in the mental health, but also in other areas of healthcare. So drawing to a conclusion, what can we do? I would say that the WHO, even before the pandemic, had designed a tool that was sort of a response to the global health security agenda that the US had set forward. And indeed, this joint external evaluations are tools that can identify eventually the blind spots or the problems we have for responding to public health threats. And therefore, it's mainly focused in three main areas, so prevention, detection, and response. And I think that these 19 technical areas are really quite significant. And mostly the joint external evaluations have been done in low and middle income countries because external funding has somehow depended on the previous assessment done by these evaluations in order to design action plans. But eventually even countries in Europe might benefit from this analysis to identify those areas where we need to improve. The process is voluntary, so a country needs to require this evaluation. They'll do a self-evaluation, and then there'll be an external team who will address the issues, and there's a public report as well. So this would be eventually an interesting tool for preparedness. Other tools, which are, they've already been mentioned, that we have these financial support that has massively increased for health and other factors. But I believe that we'll have the chance to apply it, hopefully, to build resilience. Of course, there's the recovery part that's very important, but resilience will be significant because we'll face health challenges in the future. Also, the new agency or new authority for health emergency preparedness and response will probably have a significant role in that. And also what's been designed even before the pandemic, the Beating Cancer Plan, which is also very significant for one of the causes of significant burden of disease in Europe, which is, of course, cancer.
Ricardo, I'm sorry very much to interrupt you, but we need really, okay, great. Thank
you for the time, and I'll be looking forward to the questions.
Yes, thank you very much. Well, before we continue, I would like to encourage all the attendees of this conference or webinar also to put your questions into the chat or the Q&A box, because there is space also for speakers to respond in this in the chat box. So it's not necessary, to post your questions and ask it directly, but I think it's also nice when there is an interaction in the chat. So Ricardo, once again, thank you very much. I know it's very difficult, to stop when people have so much to say, and I mean, it's also for Mariana and Claire, we would like to hear you for a really long time, but we need to move to the next person, and it's Professor Bernadette Nirmal Kumar from the Norwegian Institute of Public Health, and she's also the president of the EUPHA section on migrant and ethnic minority health. And Bernadette will share with us her views on the impact and consequences of the coronavirus on disadvantaged migrants and ethnic minorities, and what we have learned from the lessons.
Thank you so much, Iveta. I'm going to see if I can share my screen so that, can you see my screen? I hope so.
Yes, can you put it to the presentation?
Yes.
Oh, perfect.
Yes. Yeah. Thank you to the organizers, EuroHealthNet and EUPHA, of course, and all the other colleagues who have put this very important webinar together. So I'm going to try and cover this really large topic in a very short time, and that's going to be a race against time. But I'd also at the outset like to acknowledge my colleagues whose data and whose work I refer to in this presentation. I'm going to take you very quickly through COVID-19 and migration, what we know, the key lessons learned, and the way forward. I'm very glad that Claire has already paved the path for me, so I will not be repeating some of the slides that she has shown, which also actually highlight the inequalities. I think one of the important things when we talk about migrant groups and ethnic minorities, we have a lot of issues related to definition, and these definitions vary very much across the continent, as we know, and even globally. And sometimes we get a little bit mixed up, especially when we look at data. So we are talking about subgroups and it's important that they're all part of one basket, but they're all also different from each other, and that's important. We also need to be reminded about how these things actually connect. And we know that migrant status or ethnic minority status has a pathway that goes directly through poverty or socioeconomic factors, but we also know that there are exclusionary processes and issues related to health service entitlement, availability, etc. So I think it's important to have this framework when we look at some of the data that we have from COVID-19 and migrants. I think that these are two really important overarching issues, and therefore I'm really pleased that this is being given some attention when it comes to looking at inequalities. So very quickly, what has happened in the last year and a half is basically an exacerbation of pre-existing structural factors in migration context. I think that migrants have often, we know that there's an interaction of multiple factors that puts them at higher risk. But with COVID, we've seen that they're at higher risk for COVID infection, high morbidity and mortality. And I think that the issues are related both to within the health systems, and within the health system, we're already familiar with gaps to access, quality of health, language barriers, and other barriers that actually prevent migrants from accessing healthcare. But also the other existing inequalities within our society that are beyond or outside the health sector, that include living conditions, poor health and comorbidities, and the economic precarity. And I think the previous presentation from Ricardo just highlighted how important some of these factors are, because we can't look at these factors in isolation. And then above all, we mustn't forget the political factors, which is the existing social and political responses to migration, migrants, ethnic minorities. And I think this is very important. And some of it has really worsened in the last year. And I will come back to this when I talk about the policy issues. There are two large systematic reviews, and I'm sorry I haven't included the second one, which just came out recently, and that was the second wave review. And this is the first wave systematic review that was done by colleagues led by Sally Hargraves in the UK. And we can see that we have data from nearly 82 high-income countries. So what did the data tell us? The data told us the following, and we looked at the clinical outcomes as cases, hospitalization, and deaths. And we know that it's not just there's a large prevalence, but the important thing is a disproportionate number of cases among migrants. For example, in Norway, the migrant population is about 18%, but the number that had COVID were 41%. So that's why we call this, just to illustrate what we mean by that. There were lower rates of testing, but higher percent positivity, and outbreaks in high-risk settings such as camps, detention centers, dormitories, etc. Hospitalizations, we've had less access to evidence, and I think it's because the hospitals, they've been so overwhelmed with actually the task of dealing with COVID that data from hospitals is not as forthcoming. And we see the same issues related to deaths. And when it comes to deaths, I know that Claire has already shown this. some of the data from the UK. But I think you also look at other countries, particularly the Scandinavian countries, the Netherlands, France, and we see that there's an increase in all-cause mortality as well among migrants. And in Sweden, despite controlling for another number of factors, we still see that these differences did exist. And we're not alone on this side of the Atlantic. And if we look at the data from the US, again, it's very, very similar, where we see that, of course, in the US, they have their data by race, which we don't in Europe. In Europe, we have ethnic minorities or migrant status. And here again, you'll see that it's very clear, Black or African-American, non-Hispanic persons, 2.6 times higher, for hospitalization is 4.7 times higher, and deaths are 2.1% higher. So I think the case is very clear as to what the situation on the ground has been during COVID, and the inequalities have really been for lack of a better word, unmasked, so to speak. But what have we learned? Why are they at a higher risk of COVID-19 deaths, for example? And this is a very complicated diagram, so I'm just going to go to this side and say that ethnicity has led to differential exposure. And with infection, there's differential vulnerability, and then there's differential consequences, both in terms of disease, but also in terms of outcome, as we've seen with the deaths. We also looked at, and this is the work, this is work in progress, this is not yet published, looked at the Lancet Migration, looked at what was happening in the countries and published a series of situational briefs. And these situational briefs actually showed us that we could, particularly in Europe, divide countries into 3 categories. So there was the countries that it was for the better, where the policies were inclusive, there were specific policies, and Portugal actually has the most favorable. So Ricardo, you could answer all the questions about what Portugal did later. And an example, for example, there's a question in the chat about irregular migrants. And for example, in Bergen, this is not for the case for all of Norway, but the municipality in Bergen actually gave access to irregular migrants for the first time, unprecedented, to healthcare since COVID-19 started. Some countries, there was no gain, no loss. And for one other group of countries, everything became biosecurity driven. So there was suspension of asylum processes, resettlements, deportations, lockdown, excessive restricted public health, violation of human rights, and they were also had a very big impact on the economy for a lot of migrants who are low-wage laborers and couldn't during these lockdowns actually work. So we divide these into 4 areas. So a lot of countries did work on legal protection. A lot of countries looked at support, and with support is areas like housing, food distribution, financial care, mental health, childcare, education, communication, targeted information, public health messaging, translation and interpretation, help hotlines, and then there were COVID-specific interventions. So when we look across, we see that a lot of countries and a lot of local governments as well did rally around, and a lot of good was done. So it actually brought out the best and the worst, to summarize. Caroline mentioned Jahi, and so I'm going to briefly mention Jahi because Jahi started before the pandemic, and the 2 main goals of Jahi was really looking at how we could reduce the health inequalities and look at this through better cooperation and concrete actions. I don't have time to go into all that has been done, and we have a lot of actions that are being implemented. They are not all COVID, they're not COVID-19 related, but of course, we could not ignore the elephant in the room, which is COVID. And therefore, what we learned from Jahi was, we not just tackling inequity within the health system, because we're quite good with that. We've learned, over the years how to do that, how to address some of the barriers, how to advocate for ensuring legal entitlements and adopting and implementing migrant policies. But the challenge really lies outside the health system and looking at the upstream measures, as we call them. is really looking at, we've talked a lot about health in all policies, but I think it's equity in all policies that we're really is the crux of it. And this requires intersectoral action, which is really, COVID has, I cannot, elaborate and emphasize more the need for intersectoral action. If before COVID, there was no need for it, or it was not seen as an important need, COVID has all pushed us into saying we cannot do this on our own, and this is needed. And using the evidence to dispel migrant myths is also important. And I will now conclude saying the way forward is it's not over. We still need to continue. We still need data on the what. We have the data on the what, but the how, why, and how remain. Because if we don't have this data, inequalities but related to migrants and ethnic minorities will remain undetected and unexplained. Governance and policy, I could talk for the next day. We need to strengthen leadership efforts to improve, and unless we have that, we cannot improve health protection for migrants in each country. That has to come at the country level, both at national and local government. The exclusion of migrants and ethnic minorities actually hinders health protection for all. And we need to apply this intersectoral whole of government approach to protection of migrants. Equity is really the best practice. When you talk about best practice, vaccine equity is important. And I think when Ricardo talked about vaccine hesitancy, and some of the issues related to that is not having vaccine equity in place. National responses must include user involvement. I cannot stress that more, because we need the people themselves to really participate in that. And public health messaging must continue to adapt and extend to reach all those most at risk. Finally, WHO has said no one is safe until everyone is safe. Inclusion is the best choice that we can have. Thank you for your attention.
Thank you very much, Bernadette, for another brilliant presentation and your high-level analytical view, I have to say. Dear colleagues, it has been absolutely fantastic, and we have some questions from the audience, so I will address them because we always want to give priority to people from the audience. So I think it's relevant maybe for both of you, but maybe more this time for Ricardo. So we know when we talk about vaccine confidence that there are differences between generations, the boomers, the Generation X, and also the millennials, from where they are taking the sources of information. And actually to this, I would like to relate the question whether there are any tools available for the team leaders or volunteer groups to respond and ask for questions about the vaccine concerns. So Ricardo.
Yes, thank you, Iveta. Yes, indeed, the communication is key for vaccination implementation. So therefore, I think there are immunization toolkits, both from ECDC, if you look on the website, there's other tools from WHO, which are more generic, but also from the CDC, the American CDC. So I think there's different sources out there that are freely available that you can find in order to find the best tools to address immunization and to promote immunization. And of course, as Iveta mentioned, there's different tools for different target populations because they have different issues. They are available through different channels. So we need to address what are the most important populations, which share of the community really needs this further communication in order to increase vaccination uptake.
Thanks a lot, Ricardo. If you would have a chance or a possibility, maybe you could share some of them here also in the chat, if there is something, you know, that comes into your mind very quickly. Bernadette, maybe I would like to ask you a very controversial question. When we speak about inequalities and vaccines, what do you think the lifting the patents for vaccines could somehow help the situation, or what is your opinion about that?
Well, on the
I agree.
You agree, and Ricardo wanted to come in as well.
Yeah, well, I can just say that I think that I do understand that there are long-term implications of such an action, but I think we can't only say that because of the long-term implications, we cannot make an exception in the current situation. And as I said, nobody is safe until everybody is safe, and everybody is not going to. The safest we can do is ensure that everybody is vaccinated, and it's a real problem for both low and middle income countries, but also for disadvantaged groups. And I think that unless we have a possibility of extending this, we're not going to achieve anything, because this is not something that that can be restricted to, and we've seen that with the virus, it doesn't discriminate at all. And therefore, we know that it's been a very important thing. Of course, it's a more political issue as well. So let's not, the science is very clear, but the politics, I'm not a politician. So
yes,
I will not.
as I said, it's quite controversial. So maybe Bernadette and Ricardo, maybe you could also put some of your thoughts here into the chat, and I'm giving the floor back to Ingrid. Thank you.
Hello. Whoops. Back to the. Okay. Well, thank you very much. We've had already 4 very interesting speakers. We have 2 more to come, and time is getting short because there's so much information to convey in such a short time. This is a very vast topic. So we'll move right along to Elizabeth Bengstrom, who works at the Västra Götaland region. She is regional developer and senior advisor at the Department of Social Sustainability there. Elizabeth is, and the Västra Götaland region is a very valued member of EuroHealthNet, a lot of interesting things going on there. And she is also organizing an event just after this one at 11:30. So that is about such an important topic in this context too. It's about control and participation. And Professor Bernadette Nirmal Kumar already mentioned the importance of user involvement and participation. And just to elaborate a little bit on that, you agreed to also pitch what you're doing in that event here, just because not everyone can attend that event, or also maybe some people last minute would like to go. So just a very short introduction to what Västra Götaland is doing in this area. So please, Elizabeth, I'll hand it over to you.
Thank you so much, Ingrid, and thank you everyone for inviting me to this exciting event. I've been listening carefully to the previous speakers, and I realized that there is a lot to learn. There's always a lot to learn. And let me just give you a short little pitch of what we are doing in Västra Götaland and how we take action on all that knowledge that we have today, because we do know a lot, and we can hear that today from my previous speakers. And I would like to give you a little piece of the big public health work puzzle, because I think that working on public health is working on a puzzle with different pieces where you have to put them together. And sometimes some pieces are missing, and sometimes they're all there. But I know one piece that is often missing, and that is participatory processes. Basically we know what to do, but we don't do it very often because we miss this kind of piece. So why do we want to work with participatory processes? Yes, we have learned it's a good way of reaching success in public health, but it's mainly because otherwise we don't know what is needed. We might know a lot of good research, but we don't know what this exact particular group that we want to discuss with, what they need. And it could be quite different from our own thinking and our own thoughts. So we do need participatory process in order to reach out. And I'll give you a very short example of an experience that we've had now during the pandemic from Gothenburg. It's the north east of Gothenburg, where we have a community hospital, and people working on this community hospital have been working on community-based interventions through cultural mediators and health guides in order to increase knowledge and trust in the Swedish COVID strategy in northeast Gothenburg. As Claire rightfully pointed out, we have a huge gap between Swedes and immigrants, and we know that, and we knew that when the pandemic started. So we knew that we needed to particularly address these communities, and we have had already built some cultural and educated cultural mediators and health guides in these areas. So we immediately and quickly use these people to reach out to these particular communities. And the aim of the intervention was, of course, to minimize the spread of the COVID-19 in these geographical areas, in these neighborhoods. And it was to minimize the negative long-term health effects of the pandemic. But it was also very much to strengthen the trust in the Swedish healthcare system, because if we know that if there is no trust between these groups and the system, it will not happen. And the conclusion we've had now after a year working like this is that an intervention drawing on influence in participation and control may prevent the spread of COVID-19. We don't know exactly how and when, but we are looking into that now when we can do some evaluation of it. And we know that the intervention helps development of local structures for strengthening public health work and contribute to closing the gap. We can see that. But we also know that the main part of the work must be established on levels where health determinants for equity are found. So we know that we need to work on different levels. We know that we need to work on both in the individual, but also on a more structural and the addressing determinants, not only health and health outcomes, but also the social determinants of health. So this was kind of a successful work that we've been doing, but in this work we also are starting to think about, are we only working with the obvious? We know that there's an obvious, and we know it's obvious that we need to address and these migrant populations, and we do need to involve these groups, and we reach women, we reach certain minority groups, but there are also other groups. As Ricardo showed in his spider diagram, there are groups like people living in rural areas, for example. Västra Götaland is a big geographical area with a big town like Gothenburg, but also very much rural areas. And what about people living there? What about young men living in our rural areas? We don't reach them. We don't know what their needs are. And we need to think about what other groups, what other ways can we work with participatory processes in order to sort of enrich these pieces of the puzzle of the public health work. And why do we so often miss this piece? We know we work with all kinds of pieces, but we miss this participatory process. And why is that we miss it? And why don't we always think about that piece? And that is what we're going to be discussing now in let's say, in 10 minutes, we're starting this discussion in a roundtable event that will succeed this event. And it's my colleagues and I that has put together this program where we will explore different perspectives from the community, from the professional perspective, from the academic and the political perspectives, why we so often miss this piece of participatory processes when we already know that this is a very efficient piece for communication and for compliance to what we would like to people to do. So that was a very quick pitch of the next event. And for those of you who are interested, please join. And for those who can't join, we will record it and we might be able to put it on some websites, or it might be through the EuPHA website that you will be able to listen to it, or please contact me. Thank you very much for letting me pitch this event. Thank you.
Well, thank you so much, Elizabeth. I didn't see any questions, and I know you do have to move on very quickly, but I feel we felt it's such an important piece of the puzzle to highlight, because you can't assume, in including people, you also have to really listen to them and know what their needs are, and that comes from themselves. That can't be an assumption if you're going to limit it. So thank you so much, and again, maybe there's some participants from here who will now join and want to hear more, and if not, the information will be on the website of what you're doing. Thank you. And then last, but certainly not least, I would like to introduce Professor Hugh Fraser from Monmouth University, the Department of Applied Sciences, but also Hugh is part of the core team, Professor Fraser, the core team of the feasibility study for a child guarantee. At European level, we know Professor Fraser is really a leading expert in the field of poverty and social exclusion, child poverty and social exclusion. And we heard at the very start when we asked Clare Bambra what one theme or issue would you really focus on and highlight if we're going to crack this nut of leaving no one behind? And she emphasized the issue of child poverty. So it's a very nice way of rounding off a very rich webinar to hear much more about actually how we can do that. And that's what this child guarantee is focusing on. You can tell us a little bit more about that, Professor Fraser, but also and some of the specific interventions that you've been looking at from across Europe. So please, the floor is yours.
Thank you very much, Ingrid. I'll try and share my screen now. Okay, I just want to find slideshow somewhere. Not very successful. Oh, well, we'll proceed with this as it is. Ah, there we are. Great. Delighted to be here, and thank you very much for the invitation. I'm actually quite relieved to be here as my internet was down and I've only actually just managed to join you in time. So I'm afraid I missed the earlier discussion, but I'm delighted to hear that somebody at the beginning was emphasizing the importance of child poverty. I'll just give you a very quick sort of cursory look at what we've done in terms of the child guarantee. Just for those of you who don't know, the idea of the child guarantee came from the European Parliament, who passed a resolution, I think it was back in 2015, that every child, guaranteed that every child in Europe at risk of poverty, including refugee children, should have access to free healthcare, free education, free childcare, decent housing and adequate nutrition. And then there was a period of negotiation with the European Commission after this resolution was passed. And the decision was, because the Commission wasn't very convinced of the need for an initiative in this area, that the answer was a feasibility study. And I was part of the consortium that did that. And we had a sort of two-part feasibility study. The first part, 2018 to 2020, we were specifically asked by the Commission to look at the areas that had been proposed by the Parliament, but in terms of 4 particular groups: children in alternative care and residing in institutions, children with disabilities, children with a migrant background, and children living in a precarious family situation. And we had very extensive process over two years. And we had country studies, we had studies looking at each of those groups of children, we had experts looking at each of the policy areas, we had consultations with children, we had seminars with stakeholders around Europe, we had online consultations, and then we had a final conference and discussion, which led to quite a positive suggestion that there was a need for a child guarantee. And then in the second phase, which was ran till this year for the last year, we were asked to look more specifically at some very specific policy areas, but also to look at costings and feasibility. And I'll say a bit more about that in a moment. But just to say that out of all of that, the European Commission put forward in March this year a proposal for a council recommendation to establish a child guarantee. So it's now definitely on the books that we will have a child guarantee. What is happening at the moment is negotiation between countries on the Commission proposal. And I'd have to say that I think the Commission proposal is actually very positive, much stronger than we expected. Several NGOs are suggesting ways it can be further improved. I'm just hoping it doesn't get watered down during the political negotiation. And there seems to be a good chance, because some of the big member states are very supportive, that this will be agreed by the end of June 2021. There's also been a strong commitment to put a lot of EU funds behind the guarantee, and there might, as a result, be a much bigger proportion of EU funds used to tackle the issue of child poverty in the coming period. Just in terms of the guarantee and COVID, which is your topic, it wasn't, of course, a central topic of our feasibility study when we started, but it did emerge as a bigger issue as the work went on. And I think in particularly, it's worth noticing that the Commission, in justifying its proposal for a child guarantee, very strongly emphasizes the inequalities for children that have been highlighted by the COVID epidemic, and see that as a major factor in why there should be a strong child guarantee. But I think what we found was that what COVID did was to actually highlight and intensify pre-existing inequalities that face children growing up in poverty. And this was across the different areas of health, education, housing, nutrition, early childhood care, all those areas that we were asked to look at. And I think one could say two things from this. It increased the focus on two things. First of all, the need to ensure better access for children in vulnerable situations to quality health services, that's a sort of very uneven access across Europe. And then the second thing I think it highlighted was the need to address the social determinants of health. And especially here, I'd have sort of said decent housing. I think that became a big issue, and the living environment. And then secondly, access to adequate nutrition. And we certainly saw the problems in many countries when existing school meal services and things stopped and people had to put in new provisions to increase demands that there were on emergency on food provision, and all the effects of that on health. I think a couple of other things I would say that came out generally that were highly relevant to what was coming from COVID. The need for prevention and early support was a very strong theme that came out from the work. And secondly, the need for integrated and holistic services that cut across different policy areas and are delivered in an integrated way. And actually, I think I would add a third one, particularly having heard your previous speaker, is there was a very strong emphasis in all our consultations on the importance of participatory processes. And there's a very strong emphasis in our conclusions, but also I think in what the Commission has proposed, that the development of child guarantee in different member states should have a strong element of participation and consultation with families and children in poverty. In terms of access to health and inequalities in health, what I've listed there is just a very quick summary of what came out as the main policy areas that attention needed to be given to. I actually won't read them all out now. I think these slides will be available, and I know you're very short on time, but I think it's useful that was came out of a very sort of extensive process trying to identify where were the main gaps and barriers for children in disadvantaged situations accessing health services. And these were the range of things. And the one I would just pick out is to put in place regular health checkups, because that came out very strongly, is that there was very uneven opportunities to access those checkups. And that actually became the topic that we looked at more in the second phase. And we looked at in some detail, we looked across practice in terms of health checkups across Europe. We then identified possibly good practices, and from that drew out conclusions about the benefits, what approaches were needed, and all this is in the report, so I won't go into a lot of detail, but you can look at that in more detail. And we identified some of the, I think, the most interesting or successful countries in this regard in terms of having effective systems in place. And just thought it would be useful to highlight, we also identified a few other more targeted, these were more universal provisions where there seem to be very effective systems for ensuring that children were reached, particularly children in disadvantaged backgrounds. So we had Austria with the Mother Child Pass and early school health examinations, and just the details are summarized there, but you can read about it in the reports, all of which are available. In Germany, the German Child Examination Program again seems to work well. In Finland, the maternity and child clinics, the baby box, and the school healthcare program. And in Portugal, the child vision screening again seemed to be very good in terms of child vision. So I think there are out there, one of the things we drew from all the child guarantee process was a lot of things are missing in different places and in different countries, but there are also a lot of really good examples and case studies of things that do work that other people can draw on and build on. And we've tried to highlight quite a lot of those in the different reports. And that's just in a sense to give you a flavor. But I think we know a lot of what needs to happen. It's making it happen is a challenge in some countries. I think the other thing to say is, of course, child poverty varies in intensity in all countries, but it is striking that every country we looked at had some gaps in different policy areas that needed to be filled. So the child guarantee is certainly relevant to all EU member states. Just to highlight that other areas apart from health were important and affect health. And again, I think access to decent housing. And I'm very conscious of this here in Dublin. I work a lot, I chair a network of community organizations in the inner city. And during COVID, one of the things that's been really striking was the extent to which overcrowding, particularly amongst poor communities, migrant communities, Roma community, has been very serious in terms of the transfer of COVID. They're having worse access to health services. So the failure to have decent housing is a big effect on poor health. And then if you reach a crisis situation, it becomes more important. But these are the range of sort of policies that emerged from our studies that are needed to ensure that there is access housing, and particularly across Europe, I think the access to affordable and social housing. Of course, during COVID, one of the things that really emerged was homelessness and the need for, and in fact, we had in Ireland certainly better reaction to ensuring that families with children did get housing during the crisis that we were having problems beforehand. And we've looked at that of homelessness policies in more detail in phase 2. And again, that is available. And then also just to say that on nutrition, again, we looked in some detail at the different range of policies that will improve on nutrition, ranging from income support to free healthy meals in education, to education about good diets, and a whole range of other policies that seem to work. And again, there were examples of all of those. And we looked in more detail, particularly on free healthy meals in education facilities in our follow-up study. And again, there are good case studies on that you could follow up. And then just the other thing I wanted to emphasize was the importance of integrated services. Quite clearly, one of the things that emerged strongly, we probably knew it beforehand, but it emerged strongly during all our consultations, was the need for coordination and cooperation across services if you're going to tackle child poverty and meet the needs of children in a holistic way. And one of the things we found was really interesting examples of a whole school or extended school approach, where it's not just education, but becomes a base for a wide range of stakeholders to work together, which can apply health services, social services, youth work, as well as education, a whole range of services, so that you can meet the needs of children in a holistic way and have a better chance of actually getting in contact with the children who most need support. And again, we had interesting examples emerged when we looked at this in more detail in phase 2. And in Finland, the multi-services schools, we had very interesting, so some of that was very interesting in what works there, and good examples that other countries could develop and adopt. We looked at the family centers in Sweden, combining maternity clinics, preschool facilities, child health care, and such a mix of different policy provision. And we drew out lessons about integrated approaches and why they make a big difference. We've also made suggestions about how you need to develop integrated services so they work. Obviously, you have to adjust them to different countries' administrative barriers. So that's a very quick gallop through just a few of the things from 3 years' work that we did. But just to say that it is available on the Commission's website. There's very long and lengthy reports looking at different areas. I think you would find a lot of interesting examples, and hopefully it can be useful to you. And I'm really hopeful, and if any of you have contacts with your government in the next few weeks, urge them to support the child guarantee, to make sure that it doesn't get watered down. Try and strengthen it, to emphasize the need to have a child guarantee that specifically gets to the children in most vulnerable situations. Member states would have to develop specific action plans to implement that guarantee. Very important that they have participatory processes in doing that, and that the sort of topics you've been discussing today and the impact of COVID, particularly on children, will be an integral part of that. Thank you very much.
Thank you.
Oh, thanks so much, Hugh. Thank you for ending us so strongly on just very specific concrete actions. A concrete action, get your governments to support the child guarantee and take action. And that will already get us a very long way into making sure we leave no one behind. So ending already this initial event of the day on leaving no one behind on that note, and giving the link to the report and so many specific concrete initiatives of what is being done and what can be done. We'll certainly be looking through it much more thoroughly now also, and pulling more out for our Health Inequalities portal that Caroline mentioned at the start of this event. And it's already been very useful for that. So a huge lot of work that went into it, and very important work. And again, we've heard so much in the course of 1.5 hours now about, we started off saying that, and you said again, that what COVID-19 has really done more than anything is reinforced health inequalities, but it's also raised our awareness about health inequalities, and maybe this window of opportunity to see where the action highlighted, where action needs to and can be taken. And throughout the presentations, I don't see many comments and questions except people sharing resources. So I hope you will really use those resources. They will also be up on our website, but to now move things forward and applying those funds, the child guarantee funds that will be available, but also the funds that Caroline mentioned at the outset, to really push, as the public health community, push these kind of initiatives forward into action. No more only research. More research is always needed, but it's also that we also need to become more activists in this area with this opportunity to push that the knowledge that we've gained to the forefront in action. So I would really like to thank all the speakers on my behalf. I want to give maybe Caroline and Iveta also the opportunity to say a final goodbye, but I think again, it's been a very packed and rich session, but just a lot of food for thought to take forward the day and to take forward the year and this upcoming period, the post, hopefully soon, we're getting here, well, in Europe, in the North, a lot of inequalities globally, but to ride this wave into a better future where we indeed leave fewer and no one behind in the future. So Caroline.
Thanks a lot, Ingrid. It has been an inspiring webinar with lots of great speakers and lots of good examples and lessons learned. And I wish that all the leaders at the Global Health Summit this afternoon would be able to listen to all of these lessons in order to take them on board. Wouldn't that be great? We will do our best, EuroHealthNet, and also with EUPHA, of course. So thanks to you all, and Iveta, the last words are for you.
Thank you very much. I would say that there is no much to say, just thank you, EuroHealthNet, for organizing this very insightful webinar. So thank you, Caroline, Ingrid, all the speakers, and also the panelists for sharing your thoughts with us. And please enjoy the rest of the European Public Health Week. So I think maybe just the absolutely final thing, sharing a screen and draw your attention to the final, to the events that are ahead of us today. So just very briefly, there is still a lot of going on, and actually this is it. This is what I wanted to share at the end. So once again, thank you very much, and thanks a lot for inviting also EUPHA for co-organizing this event with you.
Thank you.
Thank you.
Thank you. Bye-bye.
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 Bye.
Bye.